Welcome to this episode. Today, we're diving into extrahepatic portal vein obstruction, or EHPVO, a significant but often underappreciated cause of non-cirrhotic portal hypertension. Chloe, this condition is especially relevant in children from developing countries, isn't it?
Absolutely, Liam. It's quite striking, actually. While in Western countries, cirrhosis is the main cause of portal hypertension, in many parts of the developing world, EHPVO accounts for a large proportion, up to about 40% of portal hypertension cases. So it's a distinct clinical entity that deserves more attention.
Right. And just to clarify for our listeners, EHPVO refers to obstruction of the portal vein outside the liver, correct?
Exactly. The obstruction is extrahepatic, meaning outside the liver. This leads to the formation of what we call a cavernoma, a network of collateral veins that develop to bypass the blocked portal vein.
That cavernous transformation is fascinating. It's like the body's natural detour system to maintain portal blood flow despite the obstruction. But even though the liver often looks normal initially, the consequences can be quite serious. Portal hypertension, variceal bleeding, hypersplenism, and even portal biliopathy.
Yes, and that's what makes EHPVO unique. The liver parenchyma is usually preserved early on, unlike in cirrhosis where the liver itself is damaged. But the portal vein thrombosis and subsequent collateral formation set off a cascade of complications.
So, today we're going to unpack the causes, pathophysiology, clinical features, diagnoses, and management of EHPVO. Let's start with etiology. Liam, what's the primary mechanism behind EHPVO? The main mechanism is thrombosis of the portal vein, but there's still some debate about whether this thrombosis is due to a primary disease of the vein wall or secondary to other factors. The causes can be broadly grouped into three categories.
Right. The first category is direct injury to the portal vein. This includes things like umbilical sepsis in neonates, umbilical vein catheterization, neonatal peritonitis, abdominal trauma, surgical injury, and tumors compressing the portal vein.
The second category involves developmental anomalies. These are rare congenital defects such as portal vein stenosis, atresia, or agenesis. There's evidence supporting this from studies showing associations with other congenital cardiovascular defects. Ehpvo and colleagues, for example, found congenital defects in a significant number of patients with EHPVO of unknown cause.
And the third group includes indirect factors. These are systemic neonatal sepsis, dehydration, multiple exchange transfusions, and importantly, hypercoagulable states. These hypercoagulable states include myeloproliferative disorders like polycythemia vera, inherited deficiencies of natural anticoagulants such as protein C, protein S, and antithrombin 3, as well as genetic mutations like factor V Leiden and prothrombin gene mutations.
It's interesting that despite all these known causes, in about half of the cases, the cause remains idiopathic.
Yes, and the pattern differs by age. In children, umbilical sepsis and intra-abdominal infections are the most common causes. In adults, prothrombotic states and malignancies, like pancreatic or liver tumors, are more frequent.
There's some controversy around umbilical vein catheterization and sepsis as causes. Some studies show a strong association, while others don't. What do you make of that?
Well, it seems to depend on the severity of infection and the use of antibiotics. For instance, LaRoche found that many neonates with umbilical vein catheterization developed portal vein thrombi within days. But Thompson and Sherlock, in a large cohort, found no cases of portal vein occlusion. So it might be that untreated or severe umbilical sepsis, especially in unhygienic delivery conditions, remains a significant risk factor. Modern antibiotic therapy probably reduces this risk.
That makes sense. Another key insight is the high prevalence of prothrombotic disorders in adults with EHPVO. One study found that up to 72% of adult patients had one or more prothrombotic conditions.
Yes, and latent myeloproliferative disorders are particularly important. They may not be evident at diagnosis but can manifest years later, so long-term follow-up is crucial.
And the prevalence of factor V Leiden mutation varies geographically and ethnically. It's common among whites but rare in blacks and Asians. In EHPVO patients, the frequency ranges from 0 to about 30%, but interestingly, in children, it seems to be absent.
That's a fascinating point. It suggests that genetic predisposition plays a variable role depending on the population and age group.
Moving on to pathophysiology, the thrombosed portal vein is replaced by a cavernoma, a tangled network of collateral veins that develop within about 3 weeks to bypass the obstruction.
You could think of it as a vascular maze replacing the normal portal vein, allowing blood to still reach the liver, albeit through alternative routes.
That's a great analogy, and this cavernous transformation is quite different from what we see in cirrhosis.
Right. In cirrhosis, fibrosis and increased sinusoidal pressure cause hepatofugal collaterals, meaning blood flows away from the liver. But in EHPVO, the block is prehepatic, sinusoidal pressure remains normal, and the collateral vessels are hepatopetal blood flows toward the liver.
So, these hepatopetal collaterals form in the hepatoduodenal ligament, around the bile duct and gallbladder, and on the liver surface, partially restoring portal blood flow.
But often, these collaterals are insufficient, leading to portal hypertension and varices.
And the collateral circulation extends to pericholecystic, pericholytical, and pancreaticoduodenal veins, which can cause ectopic varices and portal biliopathy.
Hemodynamic studies show normal wedged hepatic venous pressure, but elevated intrasplenic pressure, confirming the presinusoidal nature of portal hypertension in EHPVO.
There's also a hyperdynamic circulatory state. Patients have increased cardiac output and decreased systemic vascular resistance, likely due to extensive portosystemic collaterals.
And the hepatic arterial buffer response kicks in, increasing arterial flow to compensate for reduced portal flow, though this compensation may be incomplete.
That's important because it suggests the liver's functional status may be compromised over time, even if it looks normal initially.
Now, clinically, EHPVO can present at any age from infancy to adulthood with different features depending on age and cause.
The most common presentation is variceal bleeding, often sudden and recurrent, especially in children.
Children typically present with well-tolerated variceal bleeding and splenomegaly. Adults may have more subtle or incidental findings.
Other common features include hypersplenism, enlarged spleen, causing thrombocytopenia and anemia, and growth retardation in children.
That growth retardation is particularly striking. It's linked to reduced portal blood flow and deprivation of hepatotrophic factors.
Studies in rats and children show that portal vein obstruction leads to decreased growth velocity and short stature.
The concept dates back to Pavlov's work in the 19th century, showing that some portal blood flow is necessary for liver and systemic growth.
Resistance to growth hormone action may also play a role.
Another important clinical feature is portal biliopathy, biliary duct abnormalities caused by collateral veins compressing or ischemically damaging bile ducts.
ERCP studies show biliary changes in 80 to 100% of EHPVO patients, including strictures, dilatations, angulations, and stones.
The left hepatic duct is more commonly involved, possibly due to collateral veins at the umbilical vein junction.
The biliary abnormalities arise from two mechanisms: compression by dilated collateral veins and ischemic injury due to thrombosis of veins draining the bile ducts.
Some biliary changes improve after shunt surgery, especially those related to compression, while ischemic changes tend to persist.
Symptomatic portal biliopathy is rare, but more common in adults with long-standing disease.
Ultrasonography can detect gallbladder varices, which appear as tortuous, dilated vessels in or around the gallbladder wall.
Interestingly, these varices don't seem to affect gallbladder contractility.
For diagnosis, EHPVO should be suspected in children presenting with variceal bleeding and near-normal liver function tests.
Liver biopsy helps exclude cirrhosis.
Doppler ultrasonography is the primary diagnostic tool with high sensitivity and specificity.
It shows cavernous transformation of the portal vein.
Color Doppler is essential to detect recent thrombi, which may be anechoic on regular ultrasound.
Other imaging modalities like spleno portography, CT portography, and Mr. angiography are mainly used preoperatively or when ultrasound is inconclusive.
Now, management depends on age, extent of obstruction, and clinical features.
The main goals are controlling variceal bleeding, managing hypersplenism, and addressing portal biliopathy.
For variceal bleeding, endoscopic therapy, either sclerotherapy or variceal ligation, is effective in 90 to 95% of cases for acute bleeding.
It's preferred over emergency surgery due to lower mortality.
But endoscopic therapy requires repeated sessions and doesn't prevent complications like portal biliopathy or growth retardation.
For gastric varices, histochrome glue injection is preferred.
Rectal variceal bleeding can be managed endoscopically, but often requires shunt surgery or TIPS.
Unfortunately, TIPS isn't viable in most patients with portal vein thrombosis, so surgical shunts are the mainstay.
Surgery is indicated for patients who fail endoscopic therapy, have ectopic varices, symptomatic portal biliopathy, or severe hypersplenism.
There are two main types of shunts, total and selective.
Total shunts, like central splenorenal, mesocaval, or portocaval shunts, decompress the entire portal system but carry a risk of hepatic encephalopathy.
Selective shunts, such as distal splenorenal shunts, decompress varices while preserving portal perfusion to the liver, reducing encephalopathy risk.
Surgical outcomes have improved significantly with low mortality and rebleeding rates in recent series.
Shunt patency and long-term survival are excellent, with some patients followed for over 30 years.
Splenectomy alone is generally not recommended unless there's isolated splenic vein thrombosis.
Partial splenic embolization and splenic irradiation have been used for hypersplenism with some success.
Pharmacotherapy with beta blockers reduces portal pressure but lacks strong evidence in Ehpvo.
Anticoagulation may be used in acute thrombosis or in patients with prothrombotic states.
For portal biliopathy, symptomatic cases require intervention.
Endoscopic biliary stenting or sphincterotomy can relieve cholecystolithiasis, but definitive treatment is portosystemic shunting to decompress collaterals.
Hepaticojejunostomy may be needed if obstruction persists.
Regarding growth retardation, shunt surgery has been shown to improve growth velocity in children.
This supports the idea that restoring portal flow or decompressing portal hypertension benefits systemic growth.
To sum up, Ehpvo is a major cause of non-cirrhotic portal hypertension, especially in children in developing countries.
It's characterized by portal vein thrombosis and cavernous transformation, with distinct pathophysiology and clinical features.
Diagnosis relies heavily on Doppler ultrasound, and management is tailored to control bleeding, hypersplenism, and biliopathy.
Endoscopic therapy is effective but not curative, while surgery offers better long-term outcomes in selected patients.
The overall prognosis is good in patients without cirrhosis or malignancy, with mortality rates generally below 10%.
Many patients survive long-term with good quality of life.
This discussion highlights the importance of recognizing Ehpvo early, especially in children presenting with variceal bleeding and near-normal liver function, and tailoring management accordingly.
Thanks for joining us in this deep dive into Ehpvo.